Welcome back to the PFC Podcast. The views and opinions you are about to hear are the speakers and do not necessarily reflect those of anyone else. Now on to the podcast.
Welcome back to the PFC Podcast. This is Dennis, and today I'm with Andre. How are you doing today?
Great. Glad to be here. Thanks for the invitation.
Well, thank you very much for actually agreeing to this. So, since it's been a hot minute since you've been on here, would you mind doing a quick introduction of yourself?
Sure. So I'm Andre Kapp, Colonel, U.S. Army, retired. I retired in 2023. From my last job in the Army was as Director of Research at the U.S. Army Institute of Surgical Research. I'm an internist and hematologist oncologist by training, but basically spent my entire career working on problems of combat casualty care and working on getting blood far forward for treatment of combat casualties. Worked a lot with the Joint Trauma System, the Armed Services Blood Program, Special Operations Command to work with my teammates to deliver some of those life-saving approaches for battlefield care. Since leaving the Army, I sort of decided to take a different route from, instead of going into academic medicine or something like that, although I do continue to practice at BAMC as a volunteer and contribute to Uniformed Services University and the HEMOC Fellowship at BAMC as volunteer work. I took on a few part-time gigs that all ended up sticking, and so I'm a consultant part-time to the Biological Advanced Research and Development Authority, BARDA, of Health and Human Services on radiation and nuclear countermeasures. I'm medical director for some clinics, primary care / whatever comes in the door in interior Alaska, and a little bit of austere medicine there for you. I've also taken on the role of Chief Medical and Scientific Officer at Velico Medical, device manufacturer based in Boston area that makes equipment to spray dry plasma.
Man, awesome. And that's exactly what I want to talk about is freeze-dried plasma or spray-dried plasma with this company, Velico. So I guess just off the top, what I think makes Velico different is that it's U.S.-based, and at least I've never heard of another U.S.-based company that is at least manufacturing those things. Is that true?
Yeah, so we're the only company in the world that makes equipment for spray drying plasma in blood centers. As I mentioned, we're based in Beverly, Massachusetts, right outside Boston. All our manufacturing is done in, right outside Boston. And we have some great suppliers that are close partners in Massachusetts. The technology was developed here in the United States, invented here, made here, and to be deployed here. The whole project pretty much funded by BARDA, actually. So just to explain that, my role at BARDA has nothing to do with this, strictly focused on other types of products, but not plasma, so there's no conflict of interest there and in that role. But anyway, that's kind of that's the company's background. Now, I should mention that there's a company called Teleflex that is funded by the Department of War to make freeze-dried plasma, so FDP that a lot of people are familiar with, freeze-dried plasma. That would be coming from Teleflex. We make equipment to spray dry plasma, so the actual plasma would be made by American blood centers like Red Cross, Vitalant, Versity, others, South Texas Blood and Tissue right here in San Antonio, and by Armed Services Blood Program. And Teleflex, on the other hand, would take plasma from those centers, presumably, and then dry it themselves and then sell that product separately. So We basically empower blood centers to make dried plasma, and as opposed to making the plasma and marketing it ourselves.
Maybe a dumb question, but like, why is it important that the U.S. has its own capabilities as far as either freeze-dried or spray-dried plasma, other than spreading patriotism around the world?
Yeah, well, that's a great question. So, COVID-19 basically taught us all about vulnerability in supply chains. And, if that was sort of a reminder, if we needed one, that in wartime, we always worry about critical supplies coming from around the world. There's nothing more important than blood and getting it to where it needs to be for effective combat casualty care. What Velico's system is designed to do, and this was, a program that HHS and BARDA really thought was compelling, is that first of all, it allows for distributed manufacturing of dried plasma across the United States. There's no one single point of failure. So, if your, plant for making freeze-dried plasma is hit by a hurricane or sabotaged by some malign actor, or God forbid, hit by a missile or whatever, you're out of business, right? Our system is meant to be deployable to blood centers across the country. In fact, we make a containerized version of it that fits in a Connex. And so you can pretty much take it with you and put it wherever you want. Yeah. And so that builds in a level of security and operational control that is really second to none. You can, you're not placing orders just to one single facility somewhere. You can kind of quietly build up, whatever you need and put it wherever you need it, and you're not telegraphing. If you want to do that for sort of PSYOP type reasons, you can. But on the other hand, if you want it to be discreet, you can be very discreet. So that distributed manufacturing model is robust. It's scalable. Scale matters. The last time we were involved in large scale combat operations in Vietnam, we were sending 10,000 units a week of whole blood plus plasma to theater. Freeze drying facility is great, but they're complicated facilities that are very capital intensive, and you get whatever capacity you build in the first place. So if you could make like 10 to 20,000 units of dried plasma a year in a facility like that, you can imagine that capacity would be consumed in a large scale combat operation in I don't know, a month, maybe. So how do you surge to meet that need? And our solution allows for distributed scalable manufacturing with low capital expenditure. Clear and simple. And that's really the model.
It's kind of the same idea that people are talking about as far as like our power grids. How these the AI machines and manufacturing, like it's such a power drain. Just on the grid. If you have one warehouse that's pumping out, freeze-dried plasma, that's itself is going to be another drain that's going to hinder whatever else you're trying to run off power. But if you have smaller, spray-dried, you can distribute it over a wider area and have less of a drain on the system itself.
Yeah, for sure. Freeze-drying is definitely a power-intensive process. A large commercial freeze dryers, like a building-sized piece of equipment that, has to maintain a vacuum and cycle temperature over the course of a week to run a batch. Our devices are about the size of a refrigerator. One air compressor that drives the drying process can support 4 of these dryers. They could be operated, make about a dozen units. It's about 35 minutes to dry a unit of plasma in our system. So one operator can run 4 machines. Just think of it this way. One dryer, 1 8-hour shift run by a technician can make 12 units. So that's 60 a week. If you have that same tech running 4 devices, which is easily doable, and supported by 1 compressor, that's, 240, no, 300 a week. Yeah, no, 240, sorry, a week. Basically you can make 40,000 units a year with 1 person working 5 days a week, 50 weeks a year, 8-hour shift. It's a lot of plasma. And that fits in a couple of connexes. So you can imagine, like, you can scale this massively, for not a lot of capital expenditure, all made in the United States.
So as far as, anything that's going into the human body has to go through the FDA, has to be researched extensively to make sure everything is safe. So where is spray dried plasma in the process of going through these safety checks?
Right. So we had to do extensive, in vitro characterization of the product in order to be allowed to put it into humans. So we've done all of that. We conducted a phase 1 clinical trial that was reviewed by the FDA. It had 24 subjects. It was a dose escalation trial. So the first group got 200 mLs, like 1 unit of plasma. And then they got 400. The second group and the third group got 800 units, and they could get either 800 units of standard, like thawed plasma versus 800 of dried plasma. And it was a randomized crossover design. So you could get either the standard plasma or the dried plasma first, depending on, what you were randomized to. And then you got the second one. This is all autologous plasma. So it's people getting their own plasma back, but it's to isolate the effect of the drying versus, just normal freezing and thawing. And, there were no safety concerns. FDA reviewed this, our data safety monitoring board. Everybody agreed that there were no safety concerns. So we put it into people. It's safe to use. What's next? We're going to put it into patients. So we are planning a multi-center pivotal trial run by the University of Pittsburgh. Jason Sperry is the PI. He was the PI on Pamper and the STAMP study and Tower study and many others. Very experienced investigator and a great team run out of Pitt. This will be pre-hospital traumatic hemorrhage resuscitation, pretty much like the Pamper study, but it will have an active control, namely liquid plasma. And that's for 2 reasons. So it differs from Pamper in that regard. So Pamper was compared to crystalloid, plasma versus crystalloid. Really can't do that study again because probably nobody would agree to do it, honestly, given the results of Pamper. And also FDA wanted an active control to compare against. So we're going to use liquid plasma as a control. And it's therefore a non-inferiority study. So we anticipate that will probably start enrolling patients like beginning of 27, January 27. So in the meantime, what we have done is BARDA has funded the deployment of a couple of these, a number of these systems across U.S. blood centers, including our services blood program at Aswabel East at McGuire Air Force Base, but also at Red Cross, at Vitalant, Versity, Impact Life, OBI, and South Texas Blood and Tissue, in order for blood centers to develop their SOPs, training, do validation runs, and basically be ready to go upon completion of the trial and licensure and so forth. But that infrastructure is there to potentially support, if God forbid we needed it, an emergency use authorization or some such vehicle, just in case extra plasma manufacturing capacity is required. So that's where we stand regulatory wise. So, I mean, it'd probably take 2 years for the trial to run, and then FDA has to review the results of the trial. Yeah. So as I was saying, I think it'll probably take a couple of years for that trial to run, and then the FDA has to review it. So, hopefully 2029. Don't want to be, sort of mislead anybody. It's going to take a minute to get that done. But in the meantime, the infrastructure is being built to support its use.
So during the manufacturing process, this gets put out into plastic bags, IV bags, collection bags, versus like freeze-dried plasma. Everybody knows it comes out in like these, jam-sized friggin' glass bottles. I guess why are you able to stick it in plastic and the freeze-dried it seems like it has to go in glass? Is that just a shooter's choice or?
Yeah. So the problem with freeze drying that people have had over the years is that plastic does not like to go into a vacuum with a block of ice and be subjected to the tremendous forces that are required that are incurred in that process. And classically, there've been a lot of damage to bags and so forth that it just not worked out very well. As I mentioned earlier, Teleflex is making a freeze-dried product in the United States that will be packaged in plastic bags. And that product is not yet available. I mean, it's still undergoing FDA review as well. And how they do that is, they have their own proprietary method for doing that. Our system actually is essentially kind of like a clean room in a bag, right? So that basically we sterile transfer the plasma. We add a pretreatment solution of glycine and acid to basically stabilize the proteins in the drying process. And then that gets sterile docked to the plasma drying chamber where the hot air dries it and flows out the bottom through a filter. You're left with the plasma powder in the middle. And then that bag system then gets sealed and cut in the sealer to yield the final product, which looks like this. So this is the final product in an overwrap. You can see here, it's got 2 spike ports. So this is actually oriented kind of like this as part of the plasma drying chamber. And the plasma protein is kind of shaken down into the bag, and then it's cut and sealed, and then you put it in this overwrap. This is, pretty, you can roll it up and stick it in your pocket. No glass, 200 ml bag of sterile water for injection to reconstitutes in under 3 minutes if you know how to do it. But also it takes a little bit of training. You just basically people are afraid to shake these things and they worry about, making bubbles in it or something like that. And the answer is shake vigorously and then, kind of massage out the clumps and then shake some more. The record reconstitution time is like 2 minutes and 30 seconds. It's fast. So it's really, the product, the label is Frontline On Demand Plasma, ODP, and it's like, pretty much on demand. Yeah.
Because that looks like, I mean, just like we put our collection bags under our plates, that could easily be a storage place for that. I guess, why does it have to be sterile water or?
I'm sorry, say again?
Does it have to be sterile water or could you use like a 250 bag of LR or normal saline?
It's got to be a 200 ml. So for historic reasons, a unit of plasma has typically been defined as 200 mLs. Now, we know that in clinical practice, any given unit of FFP or similar product can contain anywhere from, like 180 to 275 of plasma. There's variability there. But for us to get a consistent drying time, I mean, all this is programmed and time, we start with a specific weight of input product and we get an output of protein that we guarantee if you put 200 mLs into it, will have a specific coagulation protein activity, right? And so to guarantee that, you have to use the right volume and you have to use the right product. So, if you used LR, that contains calcium and it could clot in the bag. Also, the plasma powder already contains like the salts that you need, right? I mean, it's the same composition as human plasma, just without the water. So if you add more salt by using saline or LR or some such thing, you're like doubling the amount of salt, or well, not doubling exactly, but you know what I mean? It's like you're adding more salt, which can actually affect the activity of, the coagulation proteins. I mean, yeah, it gets diluted in the body and stuff, but you're making it hypertonic, and that you're changing the resuscitation here. Now you're not giving plasma anymore. You're giving like plasma that's mildly hypertonic saline added, so how that behaves, I don't know, not been tested in clinical trials. Our label is going to be very clear that it's to be reconstituted in sterile water for injection, 200 mLs precisely at 250. It'll come with its special bag. But you mentioned, by the way, carrying your collection plate under your, carrying your collection bag under your plate, right? So one concept that could be done with this is to collect individual soldier plasma, and that you could be carrying a couple of units of your own plasma, right? And the medic could carry the water, so that the medic would be responsible for making sure that, yep, that's really your plasma, that it matches, whatever identification you have and so forth. This is just a concept, but you could literally carry your own plasma around. So that's, one approach that could be used. Of course, you could use, allogeneic plasma, and you could also carry that around too, if you like. But it's also a way of distributing the load a little bit across a unit. Different ways to do that.
Because normally either freeze dried or maybe spray dried, at least from what I understand, the process is essentially a giant vat of plasma, and they go through whatever drying process, and so it's just a mix of different, like they're not getting Olo titer plasma in one vat, and it's not type specific.
Well, actually, so that's not quite accurate. Okay. What historically, people like World War II historically, large batches were used and dried in glass bottles, etc. And the problem with that, of course, was that was before we knew about transmission of hepatitis by blood products. And we didn't know how to test for it. And so everybody who got it, basically, some donor in there had hepatitis, and then it contaminated the whole thing. If you are going to do large batch manufacturing of plasma, it is required to use a pathogen reduction technology. So, for example, the Octapharma product does use large batches. They still keep it type specific though. So it's not like a universal plasma. They've tried to manufacture that in the past, and they've thought about bringing that back. But really, you buy like A or AB plasma from Octapharma, right? And that process uses, it's called a solvent and detergent extraction step, which gets rid of viruses that have lipid membranes, like the hepatitis virus, hepatitis B, for example, and HIV and so forth. Now, it doesn't remove all pathogens. necessarily, right? It's just things that have lipid envelopes, but those are some of the more important blood-based pathogens. The other thing is that they also use some filtration steps. And of course, this plasma is tested for infectious diseases ahead of time and so forth. So it's a safe product. But you do have to do not only the testing, but also a pathogen reduction step just to be sure. Our process is different. I mean, actually, we could draw anything you want really in our system, plasma-wise. But what we are licensing in the United States, working with FDA on, is the concept of using fully licensed plasma as the starting material. So this would be plasma licensed for transfusion, fully tested FFP or PF24, that would then be dried. Okay. And it's individual units, so it's definitely type specific. The Teleflex product is also going to be type specific, and it's individual units as well. It's not pooled. So the only pooled plasma product in the US, it's not, it's only available under emergency use authorization, is the Octapharma dried powder. The French product that's available to SOCOM under an EUA also, that is a mini pooled product. So they will pool 10 units. They'll do 10 to 12 units. They'll do like 4 of A, 4 of B, and 2 of AB. And the kind of A and the B antibodies and antigens cancel out. And AB is kind of there as no antibodies. And net result is that you have essentially a universal product. And they use the Cirrus Intercept pathogen reduction technology for that mini pool. And so the French military, so I should mention that, our NATO, although this is a U.S., born here, built here, lives here product, our NATO allies have been very interested in acquiring this as well. And so the British military was an early adopter. They have essentially emergency use authorization if they need it, but they're going through their own licensing process in the UK. We delivered a system to the French military, and they are going to use that same mini cool plus pathogen reduction step. And then instead of freeze drying in the glass bottles, which they're doing now, they're going to spray dry it in the plastic bags that we're providing them. So the French military's got it, Dutch military, Canadian blood services in collaboration with Canadian Armed Forces, Australian Defence Forces in collaboration with Lifeblood, which is their national blood supplier, also has a system. And we're in talks with Sweden and Italy and Belgium and others. So throughout the sort of allied NATO plus, if you want to call it that, community to deploy the system. So it's already out there in Europe and not yet being used in humans, but again, they're sort of developing their systems, validating, doing their local validation, and so forth to get the product ready for use.
When it comes to like the either freeze-dried or spray-dried plasma, looking out, and the whole reason is we don't think that there's going to be enough blood to go around for everybody. I guess where would you see this in the idea of like an actual resuscitation? Where do you see this being utilized?
Well, I see it predominantly being utilized as close to the point of injury as possible. I think from a military standpoint, this would be a product that would be carried by combatants and used like in tactical combat casualty care. This is designed for use by combat medics and combat lifesavers and so forth. This is really tip of the spear technology. In the civilian world, which, of course it could be used, on helicopter evacuation, medevac and, osteosurgical, whatever. The French military has been using dried plasma as the only plasma product they deploy in their whole deployed medical system. So at Role 2, et cetera. Whether we would need to do that, I don't know. I mean, sure, we could do that, or we could have freezers at more robust Role 2 and Role 3 type facilities, assuming we're deploying Role 3 facilities. But certainly everything forward of that environment would be the right location for this. In the civilian world, this is made for EMS. Put it on the ambulances, ground, air, rural, critical access hospitals, that kind of environment. It's going to cost more to make this than, you started with a transfusible licensed product, and then you're doing a bunch of stuff to it. So it's going to cost more money. So in a standard inpatient, hospital setting, I think it would be hard to justify using a much more expensive product when you've got, the starting material sitting right there, right? So I don't really see this as an in-hospital use product where it's going to be cost competitive. I think the use case is clearly the pre-hospital environment or places where nobody has blood anyway, like small rural hospitals, standalone ERs, that sort of thing. Now, in terms of when should you use this versus whole blood? So first of all, whole blood is not available everywhere. When you collect a unit of whole blood, you've used up that donor for 8 weeks, and you can't use them for anything else. We built an entire blood system around fractionation for a reason, because it's more efficient, honestly. Whole blood may be very efficient for the resuscitation of a given patient, and certainly easier for pre-hospital and even in-hospital personnel to use, is one bag at a time. I should note that, up until now, we haven't had real head-to-head adequately powered clinical trials to know if whole blood, as we store it for as long as we store it, is in fact superior to component therapy. I mean, we know that, platelet function is reduced in the bag over time. And at the end of storage, there's no free lunch, it's not as good as the day it was collected, right? So the fresh whole blood experience from the military, that's a different product. That's fantastic. Great. Everybody, yep, we all agree. And I think stored whole blood is also a great product. But it definitely is not as good on the last day as it was on the first. That's the way it is. And so it depends on what you have, a fresher unit of red cells and plasma and platelet product might be superior to a end of shelf life whole blood product. We got to put that to the test. We don't really know. And those trials are ongoing right now. So we should have an open mind about how we think about that. But either way, there's not enough whole blood available. If you want to not waste a lot, you have to have a system in place to recycle it from ambulances to trauma centers. So the further away you go geographically from a trauma center, the harder it's going to be to do that. And in fact, some rural programs have adopted red cells and liquid plasma for precisely that reason, because they just don't see enough volume to justify the whole blood. They get a little longer shelf life out of red cells and plasma. And then the further out you go from where those centers are, they don't have anything, because, the volume of patients treated doesn't justify the enormous waste that they would have of having even red cells and plasma in liquid form on board. So a dried product that's got a much longer shelf life that's available on demand is exactly what they need, Now, it's just plasma. It's not plasma and red cells and platelets. Got it. But it's better than nothing. And we know it's better than nothing. And it's even better than crystalloid because we did that randomized trial. It was the Pamper study. And, there was a 10% absolute reduction in mortality, which is, translates to a 1/3 reduction relative risk of mortality, which is colossal. In patients given 2 units of plasma compared to crystalloid in helicopter evacuation. That's a massive survival advantage that we cannot ignore. And yet we can't deliver that. I mean, they did that trial with thawed plasma at a 5-day shelf life, and they wrote a whole paper about how much of a pain it was and how much waste there was in trying to just execute that trial to prove the point that plasma-based resuscitation would be useful. By the way, why'd that trial even get done? Who funded that? Well, the Department of War funded that to test the hypothesis that our investment in dried plasma was worth it. Now, we didn't test dried plasma in that study because it wasn't available yet. But the idea was, hey, if you can give 2 units of plasma to a casualty and put them on a helicopter and get them to the hospital in, on average in that study, it was 40 minutes from the time the helicopter got to the trauma center. So we'll say roughly an hour, maybe from point of injury, which is kind of like, golden hour-ish. I know but that's what was tested, right? That resulted in a massive reduction in mortality. So yeah, it works. And we just need to get it out there for the huge unmet need in civilian medicine and huge capability gap in military medicine. I spent my entire military career doing, trying to close those gaps. I was tasked with working on platelets first, and we got cold stored platelets approved. And that has dramatically increased the shelf life and availability of platelets from 5 days to 14 days. And the recently concluded CHIPS trial, the Department of War also funded, is going to hopefully get us 21 days. And that's really meaningful in terms of platelet availability to, outlying facilities and moving it around theater. We've done this, and we did in Afghanistan, and it made a big difference in platelet availability. So, but the other thing that did not yet get done was the dried plasma. And so that's why, when I retired, I said, well, I got to help, get this over the finish line because this is really critical. So we're getting there.
So, because what I was thinking of is just a logistics aspect of trying to get blood. Because when you think, 28 days with CPD, whole blood?
It's 35 days shelf life with CPD, whole blood. Mm-hmm.
Well, when you collect it, that's when the timer starts. It takes, days, if not weeks, to get it out to you. You have it for a week or two, and then it's already getting to the end of its half-life, right? And we're not talking about, changes in temperature, and you've taken it out and put it back, and all the things that we do that maybe you should or should not be doing with it, in the name of providing the best care for the guys we're dealing with. This freeze-dried plasma or spray-dried plasma, what was you mentioned the shelf life? It was like a year?
Yeah, so if you were to stockpile it, you want to get the maximum shelf life out of it, and that would be about 2 years refrigerated. For we'll say, deployed use at room temperature, we think a year is what we're going to get for a shelf life. Right now we've completed full stability studies out to 6 months, and those stability studies continue. We have some accelerated aging data that suggests that we'll be able to get a year, but you have to complete the full study. So we're almost there. We think we'll get a year at room temperature. What does that look like at, in whatever, the deserts of the Gulf region or something where it's, 40, 50 degrees centigrade on a bad day? Less. And we've done those aging studies. French military did that in North Africa with their dried plasma, and cooking it is not good for it. So it's not indestructible. It is a protein mix after all. So if you take care of it and you store it under controlled conditions, you're going to get better shelf life. But the way we sort of managed this, for deployed use with the French product, at least when I was involved in that program, it was kind of like once it leaves the storage area, wherever it is, Fort Bragg or what have you, and it goes out into the field, it does not come back into inventory. So if your deployment is 3 months or whatever, that's it. You use it, you burned it, but it doesn't come back home. That's what I would suggest for any dried plasma product by any manufacturer. I mean, it's just, there's under completely uncontrolled conditions, that's going to be a problem. Now, of course, if you're talking Arctic warfare, well, you can freeze the bag of dried product and it's not going to be a problem. If you freeze the bag of sterile water for injection, it's probably not a problem unless when you thaw it has developed a hole or something, and you'll know that right away. But as long as it's intact, I mean, you can freeze it. So that's good. But obviously it's got to be liquid. I mean, the water's got to be liquid to reconstitute it, but the powder's fine. Yeah.
But I mean, just imagine the difference in the logistical load of having to replace, whole blood every, month versus every 6 months on a bad trip for this spray dried plasma. Just the difference in burden of trying to keep those units supplied.
Absolutely. Well, that's the plan. And and for contingency operations, or I would say deterrence operations, where nothing's really happening, you're just kind of sitting there in I don't know, Poland or something, and or off some island in the Pacific. How do you justify keeping a whole pile of whole blood out there that is essentially all going to get red bagged within a week by the time it gets to you, right? The waste is staggering, and it's just unacceptable and unsustainable. But you'd want to have something. So what are the two things that you could do for readiness? You could have dried plasma and a characterized emergency donor panel or walking blood bank, if you prefer, and have comply with the DoD instruction that says all those who deploy will be typed and infectious disease tested, and who your low titers are and all that sort of thing. And then you at least have some readiness, right? And you have the training to collect and transfuse. And for a force that's mostly there to just kind of keep an eye on things and not, you're not taking casualties yet, that's really your major fallback. That's what you can do. And we need to be able to provide that capability. I know the Joint Trauma System is working on a unified walking blood bank training program that will kind of bring together the best of the, Marine Corps, Valkyrie and Rolo and all the others into one, sort of one ring to rule them all. And create a streamlined joint program for training whole blood collection and transfusion. And that's absolutely critical, but the bridge to keep people alive while you're collecting and getting all your whole blood together and all that, can be immediately available dried plasma. And by the way, you're not going to have enough donors immediately available if you're involved in a fight. So you need that plasma as an extender of the fresh whole blood you're going to collect from your combatant donors, right? Until the cavalry arrives with, the rest of the blood products needed. That's the official NATO plan, by the way. That's the official DoD plan. That is the plan. There's no other real plan. I mean, there's no, of course you could have other, things like tranexamic acid with you, and you should have tourniquets and all the rest of, all the things that we have in TCCC. But for resuscitation, that's the plan.
But speaking of training, does Velico have training bags to practice, just like we practiced with the freeze-dried plasma? Is there training kits available?
Well, we could make those available. We have kits. I mean, we have material that's filled with surrogate that's not like this that I just showed you here is filled with a protein powder surrogate, not an actual blood product in my backpack going through the airport or whatever. And so people could sort of train on that. But of course, to get the best experience, we'd actually use plasma. If there were interest in that, we could certainly work something out. Yeah.
Okay. Awesome. If somebody had interest or just had more questions or just wanted more information, where would they reach out to?
Well, they could, they could look at our website, or they could reach out to me. My email address is acap at veli, veli.co, co, acap@veli.co. And, or just, contact us through the website, and, be happy to, tell you all about it. I'll just throw in a pitch, that, I'll be giving a talk at SOMA, coming up here pretty soon. And, hope that some of our listeners, may be at that, event. And so, people want to engage there. That's a possibility. We just did a demo with 101st up at Fort Campbell last week, and doing another one down at JRTC. So the opportunities to kind of get your hands on it and see what this is like, and we'll be doing a little project here at the AMED, or the Center of Excellence here in San Antonio as well. Probably, I think, in April. I don't think we have a date nailed down yet, but it's coming. So we definitely look to familiarize people with technology, and I look forward to getting it out there and helping people save lives.
Well, thank you, Andy. I really appreciate you walking us through this.
Dennis, thanks so much for having me on the program, and look forward to the next one.
That's it for today's podcast. Make sure to go to our website, www.prolongedfieldcare.org. Check out our free downloads and a ton of other helpful information. Grab a bag of our fresh roasted PFC coffee, links in the description below, and stay on the bleeding edge of combat and austere medicine. This is Dennis for the PFC Podcast, out.